it's been a learning curve for us, and we're gonna plug into social media, which will be about, I don't know, a couple 100,000 dental hygienists. We just haven't.
Okay, so I'm looking for the YouTube link.
Well, I could start the introduction here, and welcome to Upstream Intelligence. And Shirley is my compadre, and we are welcoming two wonderful people to our podcast this day. And we're so excited, especially me. I know a little bit about my background is as a dental hygienist, Victoria DaCosta. I have been very interested in the head and neck and body connections since I started as a dental hygienist back in the years of early training. It wasn't taught in school to make the connections, but I started seeing the connections outside of school and in clinical practice. My background is 25 years as a clinical dental hygienist, 30 years in dentistry, and the other 20 to 30 years in research and development, and developing a way that we can track the connections between the oral and the systemic connections. Shirley, her background. Shirley, would you like to say a little bit about your background?
I graduated from my hygiene program in 1986. I had intended to be an orthodontist, and then baby number 5 decided to show up, and I was like, yeah, this isn't going to happen. So I switched into the dental hygiene program at a local technical college. And so I had 2 years of pre-dent, and then my associate's degree. And then in 1999, I went back to Marquette to finish my undergrad. So I have a bachelor's in dental hygiene, which was the fastest one I could get. And I've always been kind of an envelope pusher and a why person and a how person. And so I never really found, let's say, I never found hygiene heaven. I never really found a practice where I could fit in, and it became very difficult to practice in a way that the dentist was in charge of my license, and I was doing not dentistry, I was doing clinical dental hygiene, and there were many things that I could do according to the research, but I wasn't allowed to do because I was overseen by somebody who's owning the practice. Obviously, he should have his practice the way he wants. And so it was always kind of a kind of a thing. And then because of the internet in 1999, I began to start writing some of, you have to practice writing, because when you write the way that you think, it doesn't come across very good. So I wrote and I wrote and I wrote, and I found a lot of other hygienists that were in a hygiene heaven situation that were doing the things that I wanted to do with respect to prevention and talking to patients about other things besides floss and fluoride. And so then I started writing for a dental hygiene magazine as a monthly contributor. And then I started to be asked to speak. So I spoke all over the country and a bunch of other continents. And so that's been my way. And then, of course, I'm contrary. So I started to get mad at my audiences for not knowing what I know. And it was 10 and 15 years. I'm like, why are they still surprised to hear this? This is nuts. And so I found a new passion in airway, because I was, again, very upset when I learned about it, because no dentist had ever talked to me about it and how influential the airway was to even simple things like caries and periodontal disease. And so I just keep getting mad about new things and then learning new things and then telling people of the things I found. So there you go.
Well, this is why we have started these conversations, Dr. Chan and Vladimir, because as dental hygienists, we kept seeing disruptions in the health and the quality of care of patients and had nowhere to take it. And we were recycling the information and sometimes getting in trouble by a dentist that we were licensed underneath to work with to talk the truth. Little bit about Dr. Chan, Dr. Clayton Chan. I have a little bit of bio, and then we'll let you introduce yourself. Is a dental educator, but a dentist. So is this our first dentist, Shirley, that we have?
I don't know.
And you're our
I
first
think so.
dentist. How exciting is that? And dental educator, trainer, mentor, and consultant to dentists who span the globe from private practice to leading dental organizations. All attest to Dr. Chan's unique pioneering impact in the field of private practice, dental practice organizational transformation, and personal clinical skills development. By the way, Dr. Chan, dental hygienists would love to hear from you too. Dr. Chan has shared platforms with leading authorities in the areas of dental occlusion, temporal mandibular joint dysfunction, orthodontic orthopedics, and comprehensive restorative. He is pioneering leader in advocating the use of objective measuring technologies to bring accountability, which we'd like to hear that word, don't we, Shirley, to
Love
clinical
it.
dental practices through his GNM teachings and curriculum at OC, Occlusion Connection, the Center for Neuromuscular Dentistry and Orthopedic Advancement here in Las Vegas, Nevada. And I had an opportunity to meet Dr. Chan in person. So Dr. Chan, would you like to introduce yourself, a short little bio, and then we'll start our questionnaire.
Yeah, well, thank you, Shirley and Victoria. And it's great to be online with Vladimir. It's a great honor that you would bring this group together and have a great conversation. I wasn't exactly sure what we're going to talk about, but my subject has always been on dentistry, dental occlusion, how the bite comes together. And my background has actually originally, I was a dental laboratory technician before I got married.
That's
And
right.
then after we got married, my wife encouraged me to get into dentistry, and that's what I did. Once I got into dentistry, I really enjoyed it and never looked back. But I had many questions relating to what was going on as far as how do you relate the lower jaw to the upper maxilla? And that has always been of interest and passion for me because as a laboratory technician, we were always trying to determine how do you put the teeth and how do you do the wax ups properly? How do you articulate the upper and lower cast to make sure it's proper and comfortable and that the patient can chew comfortably without having any problems. And that has always been an interest to me. So in my pursuit of looking for answers, by the way, I'm a graduate from the Loma Linda Dental School out in California. I was raised out in the Southern California area, so that has always been the area of home base for me. Uh, Being raised among brothers that are also dentists and cousins that are in dentistry, in specialty programs as well, has allowed me to at least ask the reasonable questions. How do we relate the lower jaw to the upper maxilla? After I was asked to be the director of an institute out here in Las Vegas, I then moved from San Diego, California for my general practice, and then began to share to this institute and obviously had connections to many doctors that were coming to the program. And that brought my, um, you might say, their awareness about me and what we were teaching around the North American area and eventually around the globe. To this day, after I've left that institute, we've, as Victoria has mentioned, we started our own teaching program relating to helping doctors understand these key principles of not just how to find the bite objectively and physiologically to a standard that I think will help bring stability to the overall posture, to the head, the neck, the lower hips, down to the knees and feet. How this is very important and how the bite, I believe, is one of the missing key components. And many in the dentistry world do not understand the detailness of how proprioceptive signaling can play a role in the central nervous system, the autonomic nervous system, autonomic systems, parasympathetic, and basically the functional skeletal relationships of the jaw. So details do matter, but fortunately, the human being is able to adapt quite a bit. But when they can no longer adapt, this is when we have the problems. And this has been my interest and pursuit to find the answers for that.
Thank you, Dr. Chan. And I know that's a growing interest. And that's why Vladimir, when I met Vladimir and we started discussing this very issue, his new business, the Human Reset, probably is a branch of what is happening because of the symptoms. Vladimir, would you like to introduce yourself and a little bit
Yes,
about
hi,
your
and thank you for having me. And it's a really pleasure to be here with Dr. Chen. I love discussing these things. So I study chiropractic manipulation in Europe, but what I got excited about is this upper cervical reset. It was called the Atlas Proflex method, but I learned it in Switzerland about 20 years ago. And and I saw how the neck relates to, posture and other things. And it was like a kind of like a hack or, a secret way to correct things. Um, about 10 years ago, I met Dr. Michael Mew, an orthodontist from London, and we went and met a lecture in Hamburg, and he's the first one that correlated the dentistry with posture, with airways to me, and I was pretty excited and fascinated about that correlation. Also, in my experience, I found that a lot of experts in their field, it becomes a conversation of like my school versus your school kind of thing, and then it leads nowhere. So I'm always happy to work with experts in their field and see how I collaborate and see how what we can both learn, um, because there's a lot more that we don't know than we do know. It seems to be the more I learn, I find that. So I'm really happy to be on this journey and discovery with you, and yeah,
This is wonderful because my background, as both of you know, is a dental medical thermographer. And I extended that out because I started seeing in thermography, we see the issues of stress in the nerves with a red color and a red color on a body's image. And if Shirley, if it'd be okay if I could share my screen.
You should be able to.
Okay, I'm going to share here and okay, so here's my screen. Everyone can see this here. This is a case that I just imaged. Can everyone see this okay?
Yeah.
Mhm.
yes.
Okay. You can see right now, Dr. Chan and Vladimir, how she's got the floor. She's had pain, chronic pain for 5 years. And in her travels, and she's fallen, and she was in as her history timeline, I found out that she fell out of a crib when she was a baby. Her mom was actually there with the scan when she was 6 months old, fell on her head as a baby. And then she did it twice, not once, but twice. So like Dr. Chan said, she grew up accommodating, she wasn't really in stark pain. And then we had a case where she started riding horses and falling off of horses. And then we know what that will happen. Then she broke her leg falling off a horse. And so, if with these kind of cases here, you can see that she's got this chronic pain and this red in her case here. Even here will show you that, I keep seeing these kind of cases and wondering, and highlighting where the issues of stress are on the nerve. And I came across this understanding a while ago that the atlas and the mouth have an association with what's going on with her. So this is where I'd like to, have this conversation with the doctors or Vladimir is the interest is now and I've done hours and thousands, hundreds of hours of reading about this. This is a current issue, current interest that's happening, and it will not go away. We have dental sleep businesses starting. We're addressing sleep apnea. We're addressing airway, like Shirley was talking about. My research led to Dr. Fonder's book on the dental distress syndrome. I don't know if you're familiar with A.C. Fonder's book. And then Wilhelm Balters, I think he's in Switzerland. And I came across a site that had extensive research about this and video combination discussing this very issue. So I'm confused. What comes first, the chicken or the egg? And the research I found was they don't know. They said it's customized. And I said, well, how do you train customized if they don't know? Like Dr. Chen said, the dentists don't know that they'll registrate the bite to the maxilla, but what about the atlas? You meet with Vladimir, he's adjusting the atlas, but he's not working with the dentist with the bite. And you've got maybe crowns on there and implants and bridges. You've got bridges locking the midline between canine to canine. I'm seeing it all. And or you've got amalgam fillings in there that are worn down. You've got grinding. I mean, I have seen probably out of all the thousands of images I've taken, over 5,000 dental medical thermography images, not one neck was not red. So, okay, so if you have those nerve damages in the neck, now we've got cranial nerves. That was my other passion. All right, so now we have the cranial nerves, like Dr. Chan was talking about, going into the half of the brain cranial nerves going into the bite to registration through the teeth, affecting the autonomic nervous system. Here's this young girl, she's 28 that I just showed you. She has a problem with
Dr. Chan is grinning over there from ear to ear.
yeah, she can't, she has
Surely they're
so much
watching.
pain and she can't hold her bladder. You know, I look at her kidneys look fine. So we know that there's something else going on. And they've spent probably thousands of dollars on different doctors and they cannot solve her problem. I'm going to put it in your camp. Both of you ask each other questions, but what are the roles of the collaboration? And I'll just leave it open. Dr. Chan, go for it.
Well, one of the early things I've learned from my mentor, Dr. James Geary, he was a pediatric dentist, eventually relinquished his license to become a general dentist in the state of California. And his passion was early child growth and development. He recognized as a pediatric dentist that the swallowing mechanism was absolutely critical in the development of the oral cavity. Before teeth would sprout into the mouth, he recognized that the sucking mechanism or the swallowing mechanism from the child or the infant being fed on mother's breast was very critical. And he recognized how the oral cavity was being developed. And he was the one that developed the Nook Sager nipple at that time, which is a little broader nipple rather than a narrow bottled nipple for bottle feeding. But he recognized the oral cavity was the very important part of creating adequate intraoral volume so the tongue can function normally, which is a muscle. And then you would have a proper upper airway nose breathing, which was critical for child facial postural development. When the oral cavity is infringed upon and the teeth begin to erupt into the oral cavity with an abnormal tongue swallow, that is where the tongue is now functioning over the teeth and the patient or the individual is now swallowing with their teeth, with their tongue between their teeth, that creates a problem. The tongue now acts as a splint or a self-made splint to increase the intraoral volume for the oral pharyngeal swallowing mechanism, the throat, the airway. And so when that airway is narrowed down, the tongue now swallows abnormally, which is an unstable postural situation. Therefore, it will then impact the teeth and the growth and development of the dentition, where the first molars or the adult molars now begin to develop in a vertically deficient manner, which then creates overclosure and a facial development that is deficient vertically.
So Dr. Chan, in America, I don't know if Latimer saw this in Europe, but in America, there's $1 billion business pulling third molars,
Yes.
and calling
And
them
premolars.
and premolars and the wisdom tooth.
Yes.
Is this why? Because they're seeing the jaw not formed correctly because of what you're talking about?
Yes, when the jaw is not doesn't have adequate room to accommodate the tongue, and both vertically, anterior posteriorly, frontal laterally, and in the other dimensions of pitch jaw roll, as we call it, the teeth now begin to crowd. specifically the anterior teeth, begin to crowd up behind the upper anterior teeth. And so you see crowding. And so naturally, as dentists, you would think, well, there's not enough space for the teeth. So let's go ahead and remove certain teeth, like two bicuspids, for example, on one arch, which is really each bicuspid is at a minimum of 5 to 6 millimeters in mesial distal width. So you now removed how many? About minimum of 10 to 12 millimeters of arch length space out of that arch. So now you then collapse it and retract or bring the teeth together. And now the tongue has no space to function normally. So now the tongue is acting as a functioning unit, creates instability for the patient.
Mhm.
Yeah, and that's kind of the things that we see as dental dilemmas.
Do you now, Vladimir, do you have a question about this? Because
Yeah,
I
I
see
have questions. I have so many questions and lots to
Yeah.
say, but
go for it.
first, do you think that is because of lack of mastication, because of industrialized nations, processed foods, etc.? I know Dr. Michael Mew mentioned that and how that correlates to the crowding of teeth and the tongue. And does that seem to be the factor in your opinion?
I think that that is a factor that does come in. Of course, dietary habits, yes.
Yep.
But I
Okay.
think when it gets down to it, yes, you do want to have normal, healthy diet, no sugar, decrease the carbs, all that things that we're starting to be very aware of. But I think the key fundamental part is early childhood development and having adequate intraoral space for the mouth to develop into. So many of the GP functional oriented dentists have recognized that early development was important. But as a dentist here in Las Vegas, I treat mainly patients that are now not just children, but
They're already
mainly
crippled.
the adults. Yeah, they're flying in because they've had a lot of problems. TMJ problems is what you call it. TMJ is really the
Tongue posture
the
problem.
fallout of when dentists didn't understand the basic core principles of early development and proper dental occlusion. So when we go through all the different dental procedures from fillings, composites, crowns, to ortho, to implants, to whatever you want to do to a patient's mouth or their teeth, and you don't know what's happening to the musculoskeletal issues, then you call that TMJ or a psychosomatic problem, and then we don't know what to do with it, and that becomes a so-called specialty in itself. But really, it's the fallout of the lack of understanding of the key principles of how the laws of jaw dynamics should be working.
So
Yeah, so
Vladimir, how do you, when you have your cases that
yeah,
isn't this the fallout that he's talking about?
yes.
Okay.
So first, I see things through the lens of from behind, from the neck, right?
Sure.
Also, what I've learned, talking to many dentists, and we did some studies relating to occlusion and bite, and the neck work, the reset or the Atlas Prophylax method, the Atlas adjusting method. I learned what a delicate balance that is by changing teeth and fillings, and how it really shifts this very delicate balance of our bite and the distal impact that has on our neck and temporomandibular joint. So for clarification, I learned this method of adjusting the atlas, like I said, in Switzerland about 20 years ago, and I treated over 10,000 patients since. So what I learned is that the atlas doesn't move as much as we initially thought it would. And what we learned since then is that the suboccipital muscles have this proprioceptive function, specifically the rectus capitis posterior minor. And what they found that the suboccipital muscles actually attached to the brainstem, the posterior horn of spinal cord, where the pain tracks are. This myrodural bridge, they call it, goes from muscles to the outer layer of the spinal cord. And when the neck is tight, especially the tech neck, right, that we have, is then it creates that tension and pulling of the spinal
Yes.
cord. They're causing attaches where the pain tracks are, so causing pain, localized pain, or generalized or distal pain, and also causing restriction in movement. But specifically relating to the jaw, and this is where we get into the good part, because we're getting into the what we don't know. So what we learned is that when you push the suboccipital muscles, it's right underneath the origin of the trapezoid in here. When you push it, the body goes into this reset mode. And the first thing that I notice, a lot of patients say like the jaw drops. It's almost like when a cat, when you pick her up at that part, it just goes into like a, this mode. So like the body goes into this reset mode. Um, and what was surprising to me is that one of the first things that patients notice that the jaw is relaxed. So the TMJ is reduced, in some cases eliminated. And this is where like the mystery comes in. Like, well, you have similar results. How does this correlate? And chicken and egg, there's always a conversation. But resetting the suboccipital muscles, um, yeah, so you have increased
Yeah.
in mobility immediately and that relaxed states. Also, what they found is that the suboccipital muscles have more nerve endings than anywhere in our body. So per cubic centimeter, the concentration of nerve endings. So by definition, it's a sensory organ. It's an input. And we have, and it's probably for proprioception and relating to nociception, also relating to pumping cerebrospinal fluid. These are the functions that they speculate the suboccipital muscles have. So
Well,
relating. Mhm.
one of the things I've noticed, and Dr. Chen and I talked about this earlier in a meeting we had, was the body is either in sympathetic or parasympathetic. And it seems to me that most people that I scan with this technique is dental medical thermography imaging. They're in sympathetic. Their stomach is shut down. Their digestion is shut down. Their kidneys are stressed. They have lymphatic filtration that's blocking or not moving as well. The nervous system is not signaling to the body in the systemic way to move and function because they're unsympathetic. And the liver is not working. I mean, when I say not working, I mean the signals from the head and neck area aren't getting through to the rest of the body. And what's getting through is fight or flight. Now, that said, Vladimir, and we're talking about it, what about the hyoid bone? And Dr. Chan, there's the hyoid bone connection, that's the floater there that's under the mandible, and it's just kind of regulating. And is that the connector?
Well, so you have 2 points. The hyoid bone, we're not sure exactly how it relates to the reseated neck, but we found that I think relating more to the vagus nerve that regulates swallowing and breathing and speech, and heart rate and digestion elimination. We found that it probably relates to that more. I had many patients who have incontinence, even juvenile incontinence, bedwetting, that gets improved or even resolved in many cases. And then also problems with swallowing. We have people even vocalization. I treated some opera singers on my YouTube channel. You can see they're saying their vocal range increases and their output is increased with the resetting of suboccipital muscles. But I think it has to do with the vagus nerve, probably also relating to postural changes. So when your posture improves, your center of gravity literally moves up and back. And so your rib cage is more open, the diaphragm drops more. So these are the mechanical impacts of that. So I look at it through that lens rather than a fight or flight response that the body is in. Also, we could look at the when the neck is really tight, there is some kind of a fight or flight response by tensioning up, but I think it relates more specifically to different nerves and structures than a generalized, sympathetic parasympathetic response.
And this is an acute problem with the world right now. I think, I was just thinking now, I think I'll write a book called Redneck because these people have no mobility in their neck. And Dr. Chen, please,
Yes.
the proprioceptors on the surface of the occlusion are so delicate. You can feel a piece of sand when you bite between your teeth or hair. If the bite is that delicate and that sensitized and that plugged in neurology wise, how do dentists get involved with people like Vladimir? Because obviously they're laying down in the dental chair, they're putting on a crown that is on top of the nerve of the tooth, the receptivity of that tooth now, and now they're going to have vertical dimension issues when they sit up and when they start chewing. So my question is, when you start chewing, can you redneck again? Can is that why you have to keep going back to see people like Vladimir to reset the atlas? Or can Vladimir reset the atlas, C1 vertebrae, and correct the malocclusion? I don't know. My thinking is there's got to be some kind of happy medium or collaboration or communication between both providers.
Before Dr. Chen, I want to hear what you have to say, but to clarify a little bit what you said, so the resetting the atlas is probably not the most accurate way. It's resetting the muscles, and the muscles relax and go into this natural proprioceptive posture, improved posture. So I think that's more accurate. And what Dr. Michael Muse said is he said this resetting is a shortcut for dentistry because you address the things that are easy to address. It takes a few minutes. The jaw opens more, the jaw is more relaxed, and then the dental work is probably more long term and there's less work. And also you do the harder work later, you do the easy work first. And Dr. Chen, what is your take on that?
Well, there's so many great points that everybody is bringing to light, and I see them all have relevance. From a dental standpoint, as a dentist, we recognize in dentistry, we are dealing with the trigeminal nerve, the fifth cranial nerve of all 12. We recognize that the trigeminal nerve has three branches, one going behind the upper eyes, ophthalmic, then we have the maxillary, and then we have the mandibular branch. The trigeminal nerve also affects all the muscles of mastication, all the muscles of mastication. And we also recognize it affects going down to the trapezius muscles, the shoulder and neck.
Mhm.
What I teach to my dentist from a fundamental standpoint in the diagnosis of a problem, and I have a couple little teeth here,
Wonderful.
all right? When the patient comes in, all right, we're talking about muscles, as Vladimir pointed out. When the patient comes in and says, I have temporal side headaches, what does that mean to us as dentists? To me, as a G&M-minded dentist, when the temporal muscles are hyperactive, it tells me that the posturing of the jaw is posterior to really where it should be. When the jaw relaxes forward, we recognize from EMG studies that the muscle of activity of the temporals shut down and quiet. What that does is when the jaw slightly relaxes forward, now there is a posterior vertical deficiency in the bite. Now, when the front teeth begin to touch more than the back, guess which muscles now become active? The facial muscles, the masseter muscles, and you'll get frontal headaches, which then creates an occipital tension in the back of the head and neck, and the head will now be thrown upward and forward a little bit to compensate for the vertical deficiency, all right? So when there is posterior teeth not functioning properly and supporting that proper closing position, the temporal muscles will become active, the facial muscles, masseter muscles will become active, and then you have all the occipital muscles that activate, all right, from that perspective. And then we recognize that the tongue muscle is now entrapped, trying to shim up the posterior vertical deficiencies to compensate for that problem. As the teeth begin to crowd on the lower anterior region, the jaw now begins to accommodate further back and holding that position as the accommodated position. So many people think and believe that it's normal to swallow with your tongue between your teeth. And I'll say, absolutely, that's an abnormal pathology. Because when you have the teeth properly developed vertically and on the anterior posterior relationship frontolaterally, the tongue now functions within the oral cavity and is no longer entrapped. But when the jaw is posteriorized, this intraoral volume actually becomes narrower and it narrows down the throat, affecting the hyoid, all the musculature. You have narrowing of the pharyngeal spaces, the tightening of the vocal cords, and things like this. So we've treated also patients that come in with Minnie Mouse voices, or they're singers that they can't, speak properly or sing properly. But then it also affects the cervical neck musculature. The third component to our occlusal philosophy is not only do you need to have a balanced, even bite on the proper trajectory or the proper closing path, but the jaw should be able to slide left and right when it mechanically does, not that it normally does, but when we dentally move your jaw left or right, what teeth should actually be touching to keep the muscles optimal?
Yeah.
All right? When the teeth should slide, basically the front anterior teeth from canine to canine, anterior, central, incisor, should all lift and separate the back teeth. So all the muscles of the cervical neck, the muscles of the sternocleidomastoid area, the shoulder, temporalis, occipital, the temporalis, and mastoid should absolutely quiet down, including the pain inside here, the styloid process area that becomes hyperactive. These are the muscles that become unknown to many dentists as TMJ. This is very common. The temporalis, the masseter tension, the unresolved cervical neck SCM tension, the pain in the corner of the jaw, and occipital are all what we call as TMJ, right? This is the TMJ pain problems typical. And these we recognize are because of the lack of proper functioning of the dental occlusion. So not only will the jaw should be able to function freely on the anterior teeth, and nothing should be touching in the back in both the lateral movements or even in hyperlateral as we talk about occlusion connections. When the jaw goes hyperlateral left or hyperlateral right, if you have posterior teeth dragging or contacting, it will trigger SEM tension that's unresolved.
So
It
that
will
you're
trigger pain. Yeah,
so
it will trigger
basically
here.
chewing a nut could throw your neck out.
Absolutely. And therefore, it increases more root canal problems. And
Mhm.
then when the doctors put new crowns on here and they're too large, and you have hyperlateral interferences in that hyper crossbite, which doctors don't check, you get unresolved neck tension problems. All right.
Oh, and
So,
migraines. Why is it?
yeah,
And
same
every
thing.
single patient, once I learned about Dr. Bob Walker, chiropractor, started using Dr. Fonder's technique in chirodontics. He was combining the chiropractors with the dentist, training them. Now, we've talked a little bit about this, but just for fun, when he taught me about orthodontics and the side effects, you have these beautiful straight teeth, and supposedly they're touching right after they were in braces for 2 to 3 years, some 4 years, headgear, rubber bands. I mean, the whole shebang. These people are in their 40s now, 30, 40s, and I ask them, do you have headaches? Oh my gosh, I have migraines.
Mhm.
100% of my orthodontic patients that I saw as a dental hygienist always complained of migraines, every one of them. Is that the reason? Because of the
Well,
disruption,
yeah.
and they yanked the teeth out, right, Shirley? And their airway was closed out probably. Yeah.
I'm waiting for my turn. I'm going to throw a bunch of things in here. So keep going.
Well, I want to say, Dr. Chen, you said something interesting. First of all, I thought we were going to solve problems. Looks like we identified a bunch more.
Yeah.
This is
It's a
why we
very
need a
delicate and
kaleidoscope of
right.
collaboration with a bunch of different kinds of practitioners. There are very few chiropractors who understand what Vladimir was just describing. And it's hard for a dentist who has an interest to find the right kind of chiropractor, which is a whole separate thing. And then, more about the tongue later, but go ahead. You asked a question of Dr. Chan.
Yeah, so I was really interesting. Thank you for showing us the complexity of the system that's so not misunderstood, just not understood,
Yes.
And it's really interesting how it correlates. And I always try to make sense of it, again, looking through the lens of the suboccipital muscles. We know that when we release the suboccipital muscles, the headaches tend to go away. The TMJ problems, they tend to reduce, but sometimes they don't and leave us a head
Yeah.
scratching. So we see how it correlates. And the way I was trying to make sense of it and understand it is when you create space and decompress the cranial cervical junction,
Yes.
like I said, the trigeminal nerves is less compressed at the root. And we all know that trigeminal pain patients, they're really miserable, they're miserable.
Yes.
So we see how that correlates, but
Yes.
there's a lot more to the equation. Now, which came a chicken egg, it doesn't really matter. Is 80% this or 20% that or
Correct.
vice versa?
Yes.
It doesn't really matter as long as the patients feel better and we collaborate and
Right.
and discover these
Yes.
solutions. It's very fascinating to me how it relates to the SCM muscle, how it relates to the occiput, the temporal muscles. We found that in general the muscles are more relaxed when there's a musculoskeletal balance, but obviously the bite is a big factor in there.
So
Yes.
let me ask
Yeah.
both of you, and once again, I'm back to the, more complex problems, but even keeping it simple, what comes first, chicken or the egg? If we adjust the bite, does it stress out the muscles if someone like Vladimir isn't working to relax them? Can we adjust the bite to relax the muscles in the neck so that Vladimir's work could even have more of an impact on their quality of life? it all stems down to quality of life for these patients. We all care about them. What I haven't seen is a solution yet, or a prioritizing of the care of treatment, or is it going to be, I take the assessments on the dental medical thermography scans, I give this information to the providers and let them work out the prioritization of the case. What is it? I'm throwing it on the table for both of you.
Well, going back to what Vladimir was saying relating to occipital, let me give you one tip that I've observed in my clinical practice for a number of years. When the jaw is opening, closing, it has to close on an isotonic neutral path. If the jaw pulls back, then we got a problem because it affects all the muscles of mastication. Now, the other thing is this. If the maxillary teeth are also pulled back and retrognathic, all right, the mandible might be in the proper neutral closing path, the unstrained path, but then the upper maxillary teeth are retrognathic. Now you have the upper teeth either edge to edge or behind, typically edge to edge. But the jaw doesn't want to function edge to edge, so the jaw naturally pulls back. Here's where the occipital issues become challenging, okay? And dentists in the Team J world, I don't believe they understand this. When the jaw hyperprotrudes, what occlusal contact should be touching when the jaw goes hyperprotrusive and they should then come together? What teeth should touch? We say at Occlusion Connections, the cuspid should touch evenly. Both left and right cuspids, upper canine, should touch in the hyperprotrusive manner. Why? Because that shuts down and quiets the occipital tension. If your jaw is touching on the upper labials or on the linguals, it's then creating a torque and unresolving occipital tension. If you have posterior teeth in the hyperprotrusive region that are contacting, you'll still have unresolved occipital tension. So having the upper arch be able to contact mainly the cuspid to cuspid on both sides should be contacting in a balanced manner, in this hyperprotrusive manner. And so, of course, doctors will say, well, when does ever the patient go hyperprotrusive? Well, they don't typically do that. Neither do we as human beings walk around with our arms in a hyper extended position, right? But when we want our arms to extend, we want it to be able to be freely moving when we can, because most of the time our hands and arms are at our sides. But anytime the jaw has any restrictions, guess what? We got a problem. So any restriction in the jaw, in the hyperprotrusive path, is also a problem. Anytime the jaw is in a retruded position, unbalanced, you have a problem as well, facially. Facial muscles and unresolved headaches that are waking up in the morning with the jaw soreness after any occlusal therapy or whatever is also telling me that the patient has an unbalanced, retruded relationship. So depending on how the patient tells me what their problem is, I can identify exactly where their occlusal problem is. If they say, hey, I'm getting unresolved neck tension here, typically when they go hyperlateral and they have a slight anti-open bite, guess what? There's posterior teeth rubbing and contacting there. So they cannot move their head and rotate properly. But as soon as you create the proper occlusal scheme like that, then they can immediately function and rotate the head with freedom. Hyper extension, flexion, side bending, all of these things all become freed up. So we say, yes, teeth dictate a lot of things, but sometimes the dictation or the dominating of the teeth are either going to be in a physiologic relationship or they're going to be in a pathologic relationship that either are taken away from happy muscles or are going to contribute to having muscles that are comfortable.
What you said was really exciting and fascinating.
Yeah.
Thank you for shedding light on this because it does keep me up at night thinking. So I see a patient, they're doing really well. And then a few months later, tension comes back, the headaches come back. And so I'm like, okay, what's missing? And again, looking through a lens of structural stability, when the head is unstable, I blame the computer, the tech neck. So you're looking for factors, and not saying that those are not factors, but like we have one more factor now that I thought about really to the extent and depth that you have. And I think the answer is we don't know really, chicken or egg, and we can find out by collaborating and looking at these things. And you said something very interesting. where the extension and flexion of the head is indicator. I tell my patients, I tell not just my patients, I tell everybody, how do you know how your neck health is? Very simple. Turn your head left and right and up and down. How's it feel? Does it work? If it doesn't
Yeah.
work, well, there's a problem. If it works, great, enjoy it. So
Yes.
that's a really good metric. That's a really good metric.
Yeah.
Rotation, function of the joint, right? Same with the arm.
Yes.
Does it move up? Moves up, great. Enjoy it. If it doesn't, well, let's look at the shoulder, right? So
Yes.
so that's a really good indicator, and it's fascinating that you use the same metric as I do,
Yeah.
left and right and up and down and see how that
Yeah.
works and correlate.
Also, same with the jaw opening. Can they open all their way without any clicking, popping, or restriction? If they have a limited mouth opening, you have a muscular problem with either the disc or
And
all
so,
the other muscles that
right.
affect the head and neck.
In most cases, our patients not just gain the mobility of the neck, but the opening in the jaw, and they seem the midline seems to align better. And we had some studies on that. They
Yes.
weren't that consistent, but there's definitely correlation of opening and also the jaw moving, moving like straight down or going sideways a little bit when it
Yes.
goes on the closing, and the popping and discomfort as well.
Yeah.
And
Yep.
so that is where there's a strong correlation between our fields, the movement of the jaw.
Yes.
But
Click.
yeah, it's interesting. Huh?
Yeah. Clicking and popping in the jaw joints indicates not necessarily it's not a painful problem always, but the clicking and popping means that the articular disc in the joint is anteriorizing or coming off. That means the condylar bone
This slides. I know that this slides over there.
is being decompressed.
Mhm.
But what causes or what prevents that from happening? If you have supportive occlusion or the support vertically in your bite on the right trajectory, it will prevent the canals from going up and back and the disc slipping down and forward, which
Yes,
then creates a restricted mouth opening if the disc is off.
right.
To
So
get
we
the disc
noticed
back
that.
on, yeah, you decompress, creates a removal of the ear congestion feelings or ringing the ears, tinnitus, dizziness, all these factors. That's why we as dentists recognize that the support of the bite helps support the musculature and the posture of the head and neck all the way down to the toe.
Great. I'm so glad you brought this up, because the yeah, for example, you talk about tinnitus. We have about 15 to 20% of our patients report a decrease or elimination of tinnitus. And then it correlates to the dizziness. And I talked to some of the actually early founders of the Epic maneuver with the inner ears and the crystals in the inner ear. And it's probably that they're acting on the suboccipital muscles when they're doing that maneuver, because, and then the patient feels better. So it's fascinating, and I'm really excited about these discoveries that we are in real time right now, learning of the connection and the correlation of the two, and the possibilities are pretty exciting
Yeah.
seeing. Again, whether it's a chicken or egg came first, there's definitely a
Well,
strong.
let me throw in a chicken or an egg. I don't know, however you want to say it. I think where we have to start with, and this is going to sound absurd, but I think we need to start with food. My lens is pre-agricultural primal people, and we need to get back as close as we can to that. We know that we have many, many, many more tongue ties now than ever before. The tongue is 4 paired muscles. It's more like a hydrostat than just a muscle. And without it in the palate, we are missing a lot of the scaffolding that we need to support the occlusion. The swallowing is also critical. And a lot of these problems started when we separated the milk from the breast. We have a whole science of breast milk, but they call it breastfeeding, but they allow women to pump and then feed out of a bottle with whatever nipple, blah, blah, whatever that is all about. And so we're missing that whole component. If you, Vladimir, and you, Dr. Chan, are not assessing tongues for tongue mobility and assessing where the tongue restrictions are, which could be as far back as under the uvula, we have a lot of patients with that kind of a tongue tie, nothing is going to work. the tech neck, Victoria and I are always yelling at each other about tech neck. There's no such thing. It's a tongue tie. If you have a tight fascia that's going all the way to your toes, your head is going to go down regardless. And that's going to impact all of this. If your tongue is tied into the airway, which all tongue ties are, they're not tied out of the airway, your head is necessarily going to go forward to open that airway, and it'll open the airway, but it'll trigger all of whatever the list of muscles that you guys just all talked about, and all of the sutures of the head from infancy on. So now all of the sutures are jacked up in your head, including the sphenoid bone, where the majority of the cranial nerves go through. And so now they're either tight or slack. And so now you have all of these other issues happening. So we have to do the tongue as well. And that is one of the missing components. I mean, we're all talking about, you know, chicken and head, and you got to move this, you got to move that. How did it get there in the first place? And obviously, if you're 45, you can't go back to the beginning. But you have to include that initial assault. And usually, I would imagine it's going to be the tongue tie, or at least low tongue posture, which you can achieve by open mouth breathing, because you have an allergic situation in your sinuses. So Dr. Kevin Boyd talks about the craniofacial respiratory complex. He is a pediatric dentist who is like leading the charge for early interceptive orthodontics, and one of the leaders in the International Orthodontic Society, where they start at 2 and 3 years old.
You brought up some interesting things, Shirley. And I know we could talk about this for hours.
We could. We can reschedule again. We have plenty of hours in our life still left.
And Vegas is not that far, so we could do this in person too.
Yeah.
I want to touch on really quickly 3 things you pointed out. You said about the frontal cervical fascia. We find that when you relax the suboccipital muscles, it immediately relaxes, aids extension, which is interesting. The second thing you mentioned is the testing the position of the tongue. There's so many metrics we can test the body with, right? So I just picked the really simple ones. I test posture, which is easier to quantify, and and then also I test mobility, right? These are some of the things I test that, you know, because you can test so many things. And the third thing you talked about is the tongue, the fascia, and I forgot. But anyway, so
it'll come to you. And I just wanted to say, if you don't release that tongue surgically, because it's a malfunction of apoptosis, which is a completely physiological presentation in a developing fetus. So if that is not removed, you can relax it all day long. You can do mouth exercises all day long. It's going to resolve. You can stretch that fascia. The histology of the fascia is a spiral, and it's going to collapse back into itself. So we need to be aware of that. We need to solve that in order to solve the rest of the problems. I see that as the nidus of many, many things.
Yeah, the last thing you want to say, talking about the agriculture and this problem, you know, dating back that far, but also we had people with poor posture before the advent of agriculture, probably, right? So it is complicated.
I was talking about diet.
Yes, right, diet. And I agree with you. Diet is huge, right? And our diets change, and processed foods, especially in the last 100 years, but also the agriculture is a huge factor. And again, it's another element, chicken, egg, and the third element. So obviously this is relevant, and I wholeheartedly agree with you with the
and the epigenetic changes that have happened in the last 3 generations have been extremely detrimental, especially with this tongue separation problem. The hypothesis of the folic acid / folate conversation and the MFTHR, blah, 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 that is interfering with that. Yep.
It's outside of our scope of expertise.
It's outside, but it's a conversation.
It correlates.
Yep.
And the last thing with the technique, you know, the technique, you're right. It's not, it predates a technique problem. This technique, it's an exaggeration and a recent factor that is improved.
And it's easy to blame.
Easy to blame, correct. It's easy to blame. Correct. But people had bad posture and neck pain and TMJ problems before the tech, before the iPhones.
So we're wrapping up in our hour, and this has been so exciting. We have a few minutes left, and I just we have the chicken or the egg discussion, and the issues have and the problems are there. I see the solution in collaboration and communication and documenting so that we can read each other's discoveries and findings and with like-minded values. Because Shirley and I have a little bit of a disagreement. I have patients who don't want any surgery for prevention, and they don't want any kind of invasive surgery. You might say, well, it's not that invasive, but there are those cases. So what are our alternatives? And is it a permanent fix when we do these surgeries? So overall, isn't it the patient we care about? And it's their magic wand, so to speak, and it's their journey. I know a lot of cases where they would say, well, that's not exactly what I wanted. What I wanted was I didn't want to be tired anymore. I'm tired of waking up with no energy, and I have brain fog. So these are emotional issues that are affecting their relationships and their families with their friends. And yeah, we can fix the problem as engineers, but most of this I see as an emotional stress on the patients, and it affects their work and environment and their job. Some of them have to leave their jobs because they can no longer function at the rate because of the deterioration of an all of a sudden. Well, we know with thermography, we can early identify issues, underlying nerve damage years before. I would love to put them in a way that a village, so to speak, and say, go and meet with these providers, and here's the information, the base, and then remeasure as they go along and as they start to increase in circulation. To me, it's all about circulation. And if we can open up that circulation in their body and with our provider collaboration communication, I believe there we have a good start with the chicken or the egg. Woody, in wrapping up, do you have some closing remarks, Dr. Chen?
Well, this has been a great discussion. Everybody hit on some excellent points that are all absolutely valid when we're treating the human being, the patient. And I think allowing the patient to be educated so they know exactly what their particular needs are, and that they know where to go to have the right treatments done for them at their stage of where they are in the journey is absolutely important. From tongue tie releases to occipital or shoulder neck support, pelvis support, to the dental support, to even, as you're talking about, the emotional support, as well as the nutritional, is absolutely all part of being a proper human being and living a healthy life. So I agree with it all.
Great.
You brought up
It's
an
like,
interesting
where are we going to
aspect.
start? But I think
I think we
my
have.
patients start when they say, I got a dental problem, so I start there. We recognize they have other things as well. So we have to, as practitioners, look at all of these factors and not rule out any one of them.
Right, the whole person. Yes.
Yeah.
Yeah, Victoria, you brought up something interesting, the mental health, the emotional health, it's a huge factor, especially nowadays, and then your physical health impacts your mental and emotional health. The mental health is outside of scope of my practice, obviously, but it's important. And I really appreciate you and your commitment to the patients, because they're the ultimately ones that benefit from this. It's the people in our communities that benefit from you getting me and Dr. Chen on this call to not just talk about it, but to collaborate and see how we can serve our patients best, put our egos aside, and really see what we do this for the benefit of others. And thank you for bringing us together and your hard work and commitment.
You're very welcome. So how can people find you? I know every time I take these DMT scans, I call them, and I have a section in what's next. Every time, every one of them 100% says, well, where do I start? Where do I go next? We have phases of care in the report, but it would be awesome to have them, at least when they watch our podcasts, that patients are interested in learning. They really are. Where can they find, where can they find?
The humanreset.com, you can probably put a link in the description.
Okay.
I learned this when I learned this 20 years ago. It was the Atlas prophylaxis method, ATLAS prophylax, and there's about a dozen practitioners in the U.S. that practice that. Um, so that's a good start. We also we developed a device, a vibrational massage device that where patients can themselves reset the suboccipital muscle, so they don't have to go see a practitioner. We developed this during the pandemic when people weren't going anywhere. So these are some things that people can help themselves. I like to tell my patients, empower them so they don't have to see me or a chiropractor or massage therapist. Dentists are different. It's hard to do that at home. But what they can do at home in terms of lifestyle exercises, postures, sitting, what they can do so they don't have to go anywhere and be dependent on anybody.
Great.
great.
Self-empowerment. I love it. And Dr. Chan, where can people locate you? And you're retired.
Well, kind of retired, kind of
Yeah.
not. This week we'll be teaching a number of doctors coming from Singapore as well. And I did see already 2 patients this week, so they've all had a lot of head and neck joint problems, and they've come from distances from Canada, etc., and LA. But where they can find us is at occlusionconnections.com. We have a number of doctors that we've trained, not just in the NM neuromuscular arena, but have come and advanced their training in the, I call it G and M, both the gnathic and the neuromuscular. So occlusionconnections.com is a great place, and they can look under the patient education section there, which gives a lot of great information so they can identify what is great, what's working, and how to find the proper doctors and qualify them to see if they're the right ones for you.
Wonderful. Thank you so much. And Shirley, any closing remarks?
Well, you were smart enough to come up with a really cool little tagline for our Upstream Intelligence program here, and that is open wide. Mostly we intend for the brain to open wide, not just the mouth. So I did want to throw that in there. And for patients who are interested in including their tongue assessment and soft tissue assessment of just their mouth, Primal Air is the website name for connecting with me at Primal Air. And then as we're moving along, Victoria and I are going to have a web page up on each one of our websites to help people, practitioners in particular, work without these impenetrable silo walls. I just imagine this. We need to have the silos, but we don't need to be impenetrable. We have to have walls that are permeable so that information can transfer back and forth between all of our little expertises.
Wonderful. And I started that years ago on my website, Dr. Links. And I used links because I thought the X was a little more interesting, and I find that it's more memorizable. Dr. Links, DRLINXS.com. And a directory, we will be listing Dr. Chan and Vladimir's information. So putting a directory on there and linking, collaborating, the walls of communication. I would love to see these villages. I know that in closing, when someone's watching this, they might say, well, I want to see them both. And, how's that going to work? Well, I think it's going to start with the scan, the DMT scans, and then from there, we'll prioritize their cases and let the providers decide where they start according to their needs. It could be that they have brain fog or chronic fatigue. They're not even complaining about jaw popping, but we know those are side effects of the engineering that's not right in the body, and it probably started at birth. And they grew into it and tolerated it. Now they've got these symptoms. But Upstream Intelligence will keep on it. And this is just the beginning of what we're all about, is sharing information and open wide our minds and really helping each other, and strengthening and validating each other's work. So thank you
I
very
would love
much.
to continue. I would love to continue this dialogue, ideally in person. And Dr. Chan, please don't retire. There's a lot more work to do.
No, I haven't retired. I'm still here.
Okay.
That's why I'm on this podcast with you guys.
Okay, I just don't. I want to make sure both of you are in sync with working this out, because I know there's a huge need, and we
Let's
really
continue the
appreciate the
dialogue
time
and
you took.
in person. You can come to LA, or I can come to Las Vegas, and we can
Oh,
get
you're
our
in
hands
LA.
on
Okay,
some people
great.
and seeing
Absolutely.
there's so much to learn. every time I have one of these conversations, I realize how much more there is to learn. And it's
Right?
pretty exciting. So
You're
Oops, I
not that
didn't know
far
that.
away.
Very